Assalamu alaikum. Can you hear me? Perfect. Thank you, Dr. Hersey, for the introduction, and thank you for the committee for the invitation. Really an honor to be with you today. So as Dr. Hersey said, we will be debating today which modality should you choose for your AFib patient. Point by point, which I'll be arguing for today, and my friend Nasser will be arguing for single shot. So a few disclosures that I'd like to share. I have no financial disclosures about any technology or any topic that'll be presented today. I have experience in both point-by-point and single shot, predominantly PFA. And Dr. Nasser, most importantly, is a very good friend. He is smart, intelligent. More than that, he is very charming, and he will try to use that charm today to convince you that single shot is the way to go. Now, you need to know that he has a lot of new, flashy technology behind him, as well as very, very expensive equipment. So if you're considering a single shot, be ready to pay. And at the end, he will tell you single shot is the way to go. Now, that is not true. So just to start off with definitions, point by point, we mean using radiofrequency ablation to apply points, as you can see in the diagram below, to isolate the veins through wide area circumferential isolation. On the right side is what we mean by single shot, where you use one application or a few applications to isolate the vein as a whole. So I'll give you 4 reasons. There are many, but I chose 4 given the format of the presentation to discuss. So the first reason is point-by-point ablation is as effective as the best single shot ablation technology available. And there are many examples, but I will show you that this is a recent Advent trial where they randomized drug-refractory paroxysmal atrial fibrillation with pulse field ablation using a pentaspline catheter or conventional point-by-point RF, as well as cryoballoon ablation. And on the right side, you see the primary endpoint after 1 year, and they're all the same. Now, the primary endpoint was freedom from initial procedural failure, which really did not happen much. You were able to isolate both the veins with both technologies, but either increase in atrial tachyarrhythmias or escalation of antiarrhythmics or a repeat procedure. And this is the graph you should be looking for, where it shows you PFA, cryoballoon ablation, and radiofrequency ablation at 1 year all had the same efficacy. So he does not have the efficacy argument on his side. Now, when you look at how well they isolate the veins, we see that with both technologies, they were able to isolate veins, so that's not a problem. And when you look at real-world data from the Manifest PF, we see the same signal. Overall freedom from atrial fibrillation and flutter over 12 months, around 70, proximal AFib slightly better, and usually slightly worse with persistent AFib. Now, this is another technology looking at paroxysmal and persistent. It's a pulse field ablation, a single shot technology, and we see the exactly same numbers. Freedom from atrial arrhythmias around 66% in paroxysmal atrial fibrillation, as well as 55% in persistent AFib. So using both technologies have the same efficacy. Reason number 2, point-by-point ablation has an acceptable safety profile, and this is opposite to what he will try to show you today. So this is a systematic review comparing 6 studies, more than 1,000 patients. 40% had PFA done for their ablation, and 56 had thermal energies, and we don't see a safety signal. They had similar complication profile, and at the bottom you see how many atrioesophageal fistulas, because I know he'll be showing you scary images of complications, but not a single atrioesophageal fistula was reported in the 6 studies. And I highlight the Advent trial I just showed you, and when you look at the complications per technology, you see that PFA and cryo had complications. So we cannot promote these technologies as safe, or I would say without complication. Every procedure we do does have complication, and when we look at point by point, we see access and stroke complication without technology-specific complication. And this is from real-world experience. We see that 1.9% is the percentage for major complication and 3.9 for minor complication. And specifically, PFA has specific technology-related complication. If you apply energy close to a coronary artery, you'll end up with coronary spasm. So, Nasser, why do you want to give my patient coronary spasm? Third reason, point-by-point radiofrequency ablation makes more economical sense than especially the newer technology, the newer single-shot ablation. To compare, one pulse field ablation in Saudi Arabia today would cost more than double a point-by-point ablation. When you look at the cost, for a single shot, for the radiofrequency, it would cost between 40 to 50,000. Cost range for a PFA ablation would be around 100 to 120. So do we have justification for the cost? That's a question for Dr. Nasser. Fourth and final and most important reason, point-by-point ablation is more flexible tool in the lab than single shot. And I think this is the most important point I would like to drive. So this is the ADVENT trial. When we look at how often did they need to do a CTI line or a flutter line, 1 out of 4 patients going for PFA had to have a CTI line. So if you're going for a single technology, single shot technology, you will need to actually bring out your ablation catheter to do a CTI line in 1 out of 4 of those patients, as well as additional ablation in the procedure. And some had to do slow pathway modification. And we know we cannot do that with a PFA or a cryo, or you can do it actually with a cryo. Now, another important point is when you encounter non-pulmonary vein AF triggers. We know they do exist in 10 to 15% of patients who are undergoing AFib ablation. The trigger for the arrhythmia is not the pulmonary veins. So if you go in, you isolate the veins and come out, you really did not treat your patient. You just isolated the veins and they'll come back with atrial fibrillation. These are usually focal and you'd need surgical precision to ablate them. So just to summarize, which modality should you choose for your patient? Well, it depends on, I showed you the efficacy, durability, cost, and safety. And I think point-by-point radiofrequency ablation does have an argument today. And there are some other points that you need to consider. Procedural experience. Is it primary PVI versus a redo procedure? Are you expecting to do flutter lines? If you encounter non-pulmonary vein triggers, what would be the strategy? And most importantly, what if you have abnormal anatomy? I would argue there are a few cases you cannot isolate with a single shot. And if we have time, I can show you an example. And with that, I'll rest my case.